Hello, everyone. Thank you for joining us for this webcast today. My name is Amelia Fernandez. I'm the leader of Education and Engagement Programs for the Medical Tourism Association. And it's my great pleasure to introduce our presenter today, Dr. Kevin Huffman. Dr. Kevin Huffman is the Medical Director for Medical Travel Associates. He is a board-certified primary care physician as well as a physician educator. He travels the world extensively educating patients, physicians, surgeons, hospitals, insurers, employers, policymakers, all about the safety and value of medical tourism. He's worked extensively with the Medical Tourism Association, helping us develop and deliver continuing medical education. And so we're really excited to have him present today. So I'm going to pass the ball to Dr. Kevin Huffman, and he'll be presenting today about the continuum of care of traveling patients.
Thank you, Amelia. It's a pleasure to have, thank you very much. It's a pleasure to be here and be participating in this webinar. The topic today is the continuum of care for the traveling patient. But before I get started, I want to talk about why this is important. The continuum of care, when we look at continuum of care, we're concerned with patient safety and best outcomes. And in medical tourism, there is a potential risk of the interruption of continuum of care. Since patients are traveling abroad or domestically, there can be an interruption. So let's take an example. If you live in Cleveland, Ohio, and you go across the street to the Cleveland Clinic, you generally have a good continuum of care. Your patient goes into the clinic, surgery is provided, hospitalists see the patient during the hospital stay. The surgical team will follow up with that patient and the acute and long-term phase. They'll eventually come back to the primary care physician within a few days. Now, when we take that patient from Cleveland to India or Mexico or Dubai, that continuum of care has the potential to be disrupted in that the patient will go to the surgeon and then come back to the U.S., and there may be no continuous monitoring of that patient. So this presentation, although directed towards primary care physicians, I understand that many of you are destination surgeons, facilitators, medical directors of employers, and medical directors for insurance companies. So there's a lot of data we're going to cover here today. Some of it will drill down fairly deep into the medical care aspect of patients, but I'm not going to make, I don't intend to make medical specialists out of you here today. We just want to cover some basic concepts of providing care to the patient before and after they travel. So we'll have a time to review questions and deliver some answers as we move along. So the continuum of care, and what we're looking primarily at the role of the primary care physician or the referring physician or the physician of origin. That physician who has been providing health care to the patient all along prior to this travel, surgical, or procedure event. We will also discuss today the role of the destination surgeons in hospitals and how they can help augment and facilitate this continuum of care with the physician of origin, referring physician, or physician of primary care physician. So we'll first look at the role of the primary care physician in pre-travel, pre-op. Then we'll look at the role of the primary care physician in post-travel, post-op. So let's look at what needs to be addressed pre-operatively. First, you, the primary care physician or referring physician, should discuss the risk benefits of surgery. Now that's independent of the travel, but just the risk and benefit of any surgery, whether the patient is having orthopedic surgery, bariatric surgery, or cosmetic surgery. You must discuss the risk and benefit of the surgery and the risk or benefit of not having the surgery. Then you go on, once you discuss the benefits or risk of a surgical intervention, discuss the additional risk of traveling for the surgery. Whether it's out of the country or domestically, there's always some risk involved with travel. And so you need to outline that carefully. Once you do that, you want your patient to sign consent forms that you discuss this and keep that in your medical records for medical legal reasons. Now, the patient should have a detailed surgical procedure consent form signed as well once he or she has spoken to the destination surgeon. The destination surgeon and his or her team will fully explain the risks and benefits of the upcoming surgery, so the patient understands from your perspective as a primary care or referring physician and from the perspective of the surgeon or destination procedure surgeon or physician what the risks and benefits are. Again, these are not only, it seems to be redundant, but there's reason for redundancy. You want to make sure the patient's clearly aware that there's risks or benefits so that if something goes wrong along the way, we can go back and document that we discussed these things. And so these documentations are important for the primary care physician. You put your consent forms in your chart, and then once the patient signs the consent form with this destination surgeon, ask for a copy of that to be in your permanent medical record as well. So preoperatively, there are certain diseases that we want to focus on prior to travel. Respiratory, cardiac, nutrition, and diabetes are some of the conditions that are associated with increased surgical risk, regardless of travel, but just for surgery in general. So you want to focus on these diseases and cardiac complications in particular. For our traveling patients, it's cardiorespiratory problems, such as pulmonary emboli or respiratory conditions that we need to focus a bit more on. So we start this process of pre-op exam and testing 3 to 4 weeks prior to travel. We will follow that patient up just prior to travel. We'll do something that's called a fit for flight examination, where we're looking at last-minute potential risk, making sure that we've gathered all of our data together. But 3 to 4 weeks prior to travel, you want to complete a history and physical, a review system, with an emphasis on the surgical procedure. So complete the history and physical, you're trying to find anything new that you may not be aware of that has developed since your last history and physical. The review systems, the same thing. You're looking for anything that may have emerged since you've last seen the patient. Maybe they have now reflux disease or they've been complaining of shortness of breath. This is the time to track down those diseases, make the diagnosis and treatment prior to travel. Focus again on the surgical procedure. So if the patient's having a bariatric surgery, you want to focus on their weight history, their nutrition history, and if they're having orthopedics, you want to look at review systems or physical examination that looks at functionality of the surgical area. For example, hip. You want to focus a little bit more on the range of motion of the hip, any sort of physical limitation. Now, you want to complete, as a primary care physician, referring physician, standard lab or diagnostic studies that you may feel necessary for a patient having surgery anywhere, whether it's across the street or across the world. But you want to contact the destination surgeon and find out what he or she may be needing. So we're trying to coordinate everything here so that there's no redundancy in testing, that the patient has testing one time and not 2 times. So if they need a sleep study, let's get it done here. If that functions best for the surgical destination facilitators and hospitals. But again, do your due diligence in terms of lab and diagnostic studies, and then find out what the destination surgeons may have. And that's 3 to 4 weeks out, gives you time to start gathering this information. Now, you want to review medications, and medications will be adjusted going over this next 3 to 4 weeks, because if you're doing your job, you're getting this patient fine-tuned. You're getting them prepared for surgery. This is an elective procedure, and so you have time to fine-tune CPAP, the diabetic medications, the hypertensive medication. You want the patient to go through a weight loss. Any patient that's overweight needs to lose weight prior to surgery. I don't care if it's bariatrics or if it's cardiovascular or orthopedics. You want the patient as healthy as you can get them. So fine-tune medications. And when you review medications, remember to ask about the over-the-counter supplements. Many patients don't consider that medication. For example, they may be taking something like Ally, which is Aleve, which is a over-the-counter pancreatic lipase inhibitor. It's a fat blocker used by some patients trying to lose weight. You want to know about those medications or over-the-counter supplements. They may be taking other herbal supplements that will interfere with anesthesia. So make sure you ask these questions about over-the-counter medications prior to travel. Now, preoperatively, you want to look at routine immunization updates. You want to make sure that this patient, adult or adolescent or whatever age group, that they're up to date on all immunizations. And what we're finding with patients who are traveling internationally for surgery, we're getting an opportunity as primary care physicians or referring physicians to update our immunizations where we might not have had that opportunity previously. So look at routine immunization, look at travel immunizations updates. I always go to cdc.gov/travel website to find out what may be developing in a certain region of the world. I just returned yesterday from Dubai, so I went into the cdc-gov/travel, looked up what may be happening in Dubai. We know that there's the MERS outbreak, which is the Middle East respiratory syndrome. It's a coronavirus, actually. And I wanted to learn more about that and how to protect myself. So you as a primary care or referring physician will want to pull this data out and make sure your patients are aware that if they're going into certain areas, there may be some risk for developing certain diseases. So we want to try to take care of that proactively. Preop exam, as the case is with any patient having any surgery, you want to limit non-steroidal anti-inflammatories or aspirins or anything that will cause excessive bleeding prior to surgery if you can. Some patients just can't stop the medication because of either aspirins being used as a cardiovascular risk reduction therapy, or the non-steroidals, they just can't function or move without them. But to the best ability you can, you want to drop those off. You want to document alcohol consumption and stop alcohol consumption prior to travel. And you want patients to quit smoking. It's just patients don't heal well who smoke. I have a lot of my international bariatric surgical colleagues who will not perform bariatric surgery on anybody who's a smoker. If they detect nicotine in this pre-op exam, they will terminate the surgery because nicotine causes such an impedance in healing through its impact on cardiovascular supply to the tissue that the anastomotic areas where they attach one part of the GI tract to another have a tendency to leak. So this is a good opportunity prior to travel to update immunizations, update medications, get the patient to limit aspirin, alcohol, and eliminate smoking. Now, I apologize if I seem to be going too fast. I'll try to slow it down a bit, but we do have a lot of slides here. This deck will be available to you after this presentation. So you go to the MT website and download it and review it. And my contact information will be provided as well. If you have questions, I can try to answer those, the questions that we don't get to at the end of the presentation. So preoperatively, you want to get patients nutritionally fit. This is particularly important for any patient having a GI procedure or bariatric surgery or any other GI procedure. You want to make sure that you document the preoperative nutritional status because things will change postoperatively. We want to make sure that the patient's healing well, that the wounds are healing well, and proper pre-op nutrition and smoking cessation are critical to that. Now we're turning attention a bit to the preoperative functional assessment. The functional assessment is where you determine the patient's mobility, hygiene issues, and these are performed in particular for patients who may have some limited mobility issues preoperatively or postoperatively. Say they're morbidly obese, they're a very large patient, they have difficulty moving around. You want to assess what physical assessments they have. You want to determine whether they are using walkers or wheelchairs or need a bedside commode. You want to determine what they may need when they return and additional assistance. Do they have patient support or a support system such as friends or family members that will come to their home and help them dress wounds or help them with their mobility issues. If this is a patient that's going out for a hip replacement, you want to determine what's going to be necessary in the home. Some cases, the folks that operate durable medical equipment companies, the companies that supply wheelchairs and walkers, will actually offer free in-home assessment. So if you have a patient going to, say, India for a hip replacement, you can contact some of these individuals in your community. They'll go in and do an assessment to determine whether this patient's going to need a walker or a wheelchair, and whether there's loose rugs that need to be addressed and those types of things. So this is an opportunity to determine what the patient's functional capacity is currently and how that might change postoperatively, and what we'll need to do to help with that postoperatively in terms of adding mobility devices or hygiene issues. So why is the flight fit for flight physical? Well, the studies have shown that if you do a preoperative outpatient medical evaluation prior to surgery, you can minimize postponement or cancellation of surgery. Now, this study was done in 1994 and was addressing domestic surgery or community-based surgery. So it's even more important that we address this for international travel. Nothing will give you will scar your reputation more than having a patient who spent 14 hours on a flight, like I just did to Dubai, to get to Dubai, and then when I get there, find out I can't have surgery because of something that could have been resolved at home. There's a fever of unknown origin, the hypertension, uncontrolled hypertension, or some other medical condition that could have been diagnosed and treated prior to arrival. Now, once they arrive, they're either going to have to be sent back or they're going to be delayed in their destination procedure, which means additional time and cost. So we're trying to pick up on things here at the last moment, just before they get on that flight, that may be a red flag. So just prior to travel, as close as possible, have the patient come in, answer any last-minute questions they might have, make sure all the documentations are arranged, the travel arrangements are in order, they have their passport, and the passport's actually updated. You complete a brief physical examination looking for just some basic vital signs to make sure you're not missing anything here, that they now don't have a fever or elevated blood pressure. You want to review the labs to make sure you've not missed anything from those labs that we completed 3 to 4 weeks prior to surgery. And then look at their medications, make sure the medications are, the patient has the medications and they're available for to travel. These patients should be taking these medications in original pill bottles to their destination. The other thing you want to do here is look at any CPAP adjustments or other therapies that you prescribe just for the travel itself. Some patients may not do well with traveling. They may need anti-anxiety medications or maybe sleep medications or something to get them through that process as well. Now, when you have them there and you've completed all of your assessment and you're assured that they are ready now to fly, you now have an opportunity to reinforce what's going to happen at the destination, to talk about acute care at the destination. So you're going to review the surgery again. You're going to review the process that the patient's going to go through at the destination in terms of acute care. You're going to schedule an office visit with the patient so that immediately when they get back, as soon as possible, they come back to you, the referring physician or destination physician. And the reason we want this done is that we've seen in the past where patients haven't been followed up and they've gone on to develop major complications that were minor issues initially. Then maybe they had a little redness around the wound, a little minor cellulitis that could have responded to an antibiotic. And now the patients ignored it. They haven't followed up with their primary care physician or haven't found a physician willing to care for them after their travel. And it's gone on to develop an abscess where they're now in the ICU. So this is critical that the patient follows up with their primary care physician, if not their primary care physician, a physician in that community that is interested in providing that pre- and post-operative care. Now, this topic is something that we'll discuss later at another webinar. I'd like to address how we can network with physicians around the world that can provide pre- and post-travel care when the patient's personal physician will not provide that care. Because some personal physicians will simply discharge the patient if they travel for surgery. We saw that in bariatric medicine, the field that I'm from. Patient traveled for bariatric surgery or didn't travel. They went locally for bariatric surgery. Primary care physician says, I don't believe in that. I think it's dangerous. And they discharged the patient from the practice. So the patient now was left with no care. So we'll address that further down the line, but currently we're addressing this as if the primary care physician is engaged. So the primary physician is going to ask the patient to come back immediately. Now, another issue that you want to cover on this fit-for-flight examination is to discuss again any in-home clinical care visit by nurses or dietitians or PTs or OTs that the patient may need. Remind the patient that when they get home, that their second day home, there's going to be a physical therapist or an occupational therapist there to greet them to start their rehab for their hip replacement. You want to gather all pertinent medical records as the physician of origin, and you want to you need to transmit those to the destination hospital or physician or surgeon. That can be done simply by putting those records into a folder and handing them to the patient. It can be done through some of the hospitals. Destination hospitals have secured HIPAA-compliant portals. At some point, I believe we will have HIPAA-compliant technology through email. It's not there yet, so I don't suggest you send an email, but eventually I think we'll have that. But a lot of hospitals do have secured portals where you can transfer that information. But the destination surgeon needs to see your medical records as the primary care or referring physician. I addressed this moments ago about bringing the medication in original bottles. We really need that. Because the patient may say, doctor, I'm taking a pink tablet or a blue pill. We don't know what it is. So we want to know what it is. We want to know how it's prescribed. It may be prescribed 3 times a day. The patient's taking it once a day to save money. So remember, this is important. It's important for the patient to take that in the original pill bottle. If the medications are not in the original pill bottle, that pill bottle may get seized when they go through customs. So remind them, it's got to be, those pills in that bottle have to go with that prescription on that bottle. Discuss again the support system that the patient may have. Who's going to be there to help them dress their wounds, care for them? Is it a family member, a friend? Is it a visiting nurse? Discuss postoperative care, what they can expect after destination, how that care will be, how that flow of care from pre-op to operation to post-op to the step-down unit to discharge into the hotel or discharge into the med-surg floor. So the patient is comfortable with that. Now, this is something we're after a primary care physician to do, but it's also the primary responsibility of this is the destination surgeon and his or her team or the facilitators. There should be no guessing about how the patient progresses through all these steps. Now, again, you discuss what you want the patient to bring to your attention when they return. We want the patient to immediately show up in our offices as a primary or referring physician. But if they see something between visits, say they come the first day and then they don't come back for a week, and in that interim they develop swelling or discharge or redness, we want the patient to be aware that these are things that we want to be aware of. They need to contact us so that we are aware of these things. So give the patient a list of things that you want them to contact you over. And then finally, you want to review the discharge summary and acute care plan. So you'll have some opportunity to discuss long-term postoperative care, but you can begin this conversation at 3 to 4 weeks prior to the examination or prior to travel, and then on the fit-for-flight physical, you can bring up these things. The patient needs to be aware of all these aspects of the care. Once they come back to you after travel and they're back in your office, now you can get into the details of the long-term rehab, the healing process, and you have an opportunity as a primary care physician to review the operative reports and discharge summaries. The discharge orders, what the destination surgeon wants that patient to do to reach optimal outcome and risk reduction. At this return visit, you want to start scheduling all your visits. So the patient comes back to you right after surgery, you want to now lay out their visits with you and any specialty physicians. If they've had an orthopedic procedure, you might need to schedule a follow-up with an orthopedic surgeon or sports medicine physician in your community. If they've had a bariatric surgery, they may not follow up with a bariatric surgeon in your community, but if they have a lap band, for example, and it needs to be adjusted, either you need to be trained to do that adjustment or they need to find a local bariatric surgeon who will do that adjustment. You need to have backups. If they're orthopedic surgeries and they come back and there's complications, you need to develop a relationship with your community physicians to be able to drive these patients into these specialists. Now, some of these specialists aren't receptive to treating a patient who's gone out of their community into another state or another country. But I can tell you from personal experience, there are many that do. Many of them see that this is an opportunity to participate in continuum of care, and they will benefit, their practice will benefit from that aftercare. You want to discuss lab and testing as well on the post-op side. So let's look briefly at the continuum of care and the role of the destination surgeon. We talked about what the primary care or referring physician needs to do in terms of preoperative and postoperative. Let's look at what the destination surgeon and hospital need to look at. First, they need to collect all the pre-travel, preoperative medical records from the patient's primary care physician. Gather that records up. I know it's been difficult to communicate with these physicians. They're not easy. But what we hope to do through the Medical Tourism Association is to help network destination surgeons with primary care physicians that are interested. And if you have a primary care, all these patients have primary care physicians. Any patient that is traveling, regardless of where they're traveling and where they're coming from, whatever country, they have a primary care physician. And we need to educate and engage them, and that's what we hope to do through some of the programs that we offer at the Medical Tourism Association, is engage these docs so they will help and cooperate and communicate with you. So you want to gather that information from the primary care physician. You want to review the surgical and travel risk benefits with your patient and have that patient sign those consent forms and send that consent form back to the referring physician. So you as the destination surgeon keep a copy of that consent form, send a copy back to the primary care physician. You want to discuss immediate destination pre-op process with the patient. That is, once they land and they're picked up at the airport and they're taken to their hotel and then they're brought into the hospital, what's going to happen? What testing is going to happen at what times and what it will look like, and when do they get from lab and diagnostic studies to the holding room prior to surgery, and then all the steps that go along with surgery and acute care at the destination. You want to assign a patient advocate. That patient advocate should be fluent in the language of the patient, whether the patient's coming from the United States or Mexico or China or wherever they're coming from. You should have an advocate that speaks their language and their patient is very comfortable with. You as the destination surgeon or hospital, you want to review the process and estimated time of the procedure. You want to review in detail, again, what the patient is undergoing. They're having a hip replaced, or they're having a gastric bypass, or they're having a cosmetic procedure or a dental procedure, and here's what the procedure typically takes in terms of time, and this is where you'll go next. Now, if there are complications, and there can be complications, you have to be willing and able to deliver to this patient estimated cost of those complications. For example, we did a hip replacement and we had excessive bleeding, and if you have this, typically your stay in the hospital is extended by so many days or hours, and it's estimated cost. So these patients understand what potential complications develop, how long they will remain in the facility based on those complications, and potential cost for those care of that complication. Now the role, another role is to review destination post-op care beyond just surgery and acute care. What will happen once they're stable? Will this patient be transferred to a medical surgical floor, or will they be transferred to a hospital or another extended care facility where the continuum of care will be provided? Post-operative care issues. This is things that we need to discuss. The length of stay, the medications, treatment plans, and treatment plans to look at wound care, dietary, ambulatory, cardiovascular. We're going to go over all this in more detail, but postoperative care issues at the destination. Some other postoperative care issues are length of stay. So when we look at length of stay, what is a typical length of stay in terms of post-op recovery, ICU, step-down, med-surg? When will they be discharged? If something goes amiss, if there's a complication, how does that change? How does this process change, and how does the time in each of these stages change? And you want to give a patient a rough estimate. We know it's impossible to predict all possible outcome scenarios, but to the best of your knowledge, give a patient an estimate of time and cost for these stays. When you discuss medications with these patients, post-operatively, they need to know what needs to be continued in pre-op. For example, our bariatric surgical patients, we generally cut their insulin in half on the day of surgery. So they are aware that their pre-op medication will be cut in half. Now you have to talk about adjustments in other pre-op medications, for example, or other pre-op medications. Some will be adjusted, some will continue. Their hypertensive medications will continue. They had an orthopedic procedure, maybe nothing has changed pre-operatively. But you have to discuss in detail what will be continued pre-operatively, what will be adjusted in the pre-op medication, and now what's new in post-operative medication. Not only what's new, but at what duration. It's a new pain medication. It will be used for 2 to 3 days. Then you'll drop to this new medication. So in detail, in their native language, to outline the new post-operative medications. Post-operative care issues, treatment plans, how you have to talk about wound care issues, when they need to contact you, when they need to contact the primary care physician, if they see redness or swelling or interruption of the staple or suture line. You need to discuss post-operative dietary plans, if they're bariatric surgical patients, how they transfer through these phases of clear liquids, full liquids, purees, and solids. Treatment plans, you'll have to discuss ambulatory rehab. If they had a hip replacement or a shoulder replacement, or if they had some sort of orthopedic surgery, how do they ambulate? When do they need the walker? When should they be weaning off the walker? When should they be doing passive range of motion versus resistant exercises? All that needs to be spelled out in detail, and that detailed information needs to be in the hands of the primary care physician as well. And then cardiorespiratory issues. When is the cough normal? When is it not? How to proceed through cardiac rehabilitation, respiratory care, those sorts of issues. Now we're going to break down postoperative complications. We're going to talk about postoperative complications in various phases, from acute to early to a longer term complication. And we're going to drill down into these phases because this is important for the destination surgeons to address and for the referring physicians to understand. Acute complications are those complications that occur during or immediately following the surgery, typically in the recovery room. You take them back, we start seeing vital signs and changes, they've got to bleed, we have some other issues. These are acute complications, and the complications that will be addressed at the destination. Nothing that will be done at the origin or physician, referring physician. Now, early complications, those are complications that occur 1 to 3 days post-op. And these are the highest incidence of post-operative complications, and that may or may not be addressed by the destination surgeon. The patient may be at the destination, but they may have already returned home by that time. Now, this is where education of the primary care physician is so important. 30 years ago, when a primary care physician was involved with surgery, they were actively participating in the surgical care. For example, when I started my medical practice, I would scrub the cases. I would go in and be the first assist to the surgeon. So I had my hands in the surgical field. I saw the patient in the post-op. I managed the patient through the ICU, through the step-down unit, and on the floor, that typical 1 to 3 day period. So as a primary care physician, I provided care during this early complication period. Today's physicians don't do that. Today's primary care physicians are trained to provide outpatient care only. The patient typically who needs surgery goes into the hospital, has surgery, that post-operative care, immediate post-operative care is provided by the surgical team and a hospitalist, an employee of the hospital, an employee physician that provides that care. That patient may not go back to the primary care physician for up to 1 to 2 weeks, because upon discharge, they go back to the surgical team for this early phase for maybe 1 to 2 weeks. So that's the issue we are faced with in today's world. As we globalize healthcare and patients have healthcare delivered all around the world, we're breaking the continuity of care because the patient's coming back into a void. And that's the void we're trying to address with educational programs like this and our other CME-approved physician education programs. We need to get our referring physicians engaged in this early complication. So again, this early complication may be something that is addressed at the destination, but it may fall in the lap of the referring physician. Now, I've got a lot of slides coming up, only about 25 of them, and I'm going to cover these things in a matter of just a few minutes, because I don't want to get drilled down too far into these acute complications. I want you to be aware of it. This entire slide deck will be available to you to come back and review, and you'll have my contact information if you'd like to know more. But let's look at some of the acute complications, those things that happen immediately in the surgical suite or when they go to the recovery room. You get anesthesia complications, hemorrhage, vasoatelectasis with the collapse of the alveolar system in the pulmonary system. Shock is common, acute myocardial infarct, and pulmonary emboli. Again, this will be addressed by the destination hospital and surgeon. This patient's unlikely to be back at destination at their in their primary care physician. Other things that cause acute complications: surgical injury. You nick something like a nerve or a vessel. You get burns through using the cautery guns. There may be transport injuries. All those kind of things, again, are something that is more involved with that will be addressed by the destination. Early complications, these are things that go 1 to 2 days out. They may be at the destination hospital, but they could be back now in the home and the practices of the primary care physician. So things like surgical injury. If you have a surgical injury, how do you determine that? Generally, fever. You can get other signs of acute confusion, which will give you a sense that there's dehydration or sepsis. So things that you want to look for in patients, if you see these things of acute confusion or nausea, vomiting, paralytic ileus, the GI tract not moving as it should, be aware as a primary care physician. Again, most of you in the primary care community do not address this. This is something that's handled by surgical teams or hospitalists in our hospitals. But this is things that you need to review. So I ask that you review this information, do a little bit of research. We'll drill down in this much deeper in further CME programs. We may dedicate an entire CME event to just surgical complications in the early phases for the primary care physicians. I just wanted to give you a brief overview here. Other early complications are wounds not healing, anastomotic dehiscence, where there's a leaks between GI tracts, say in gastric bypass. Deep vein thrombosis, that's a biggie, and that's the one that we have to face with patients who are sitting long term. I sat in an airplane for 14 hours coming back from Dubai yesterday, and that just puts you at increased risk of developing deep vein thrombosis. So we have to do prophylactic treatments, make sure that these patients are aware of that. We may need to put them on medications to prevent that. Some surgeons may use inferior vena cava netting to catch the clots, although that's not not been widely accepted, but may be appropriate for these patients that are traveling great distances. Patients need to get up and walk the hallways, or in the airplane itself, need to be walking, moving, doing pumps in their feet, make sure that they're getting blood flow through their legs. So these are all things that they can do to try to reduce that. But this is a major complication: deep vein thrombosis and pulmonary emboli. Early complications, acute urinary tract infections, respiratory complications generally show up with fever, and they may be things that they're seeing and addressing at the destination. It could be something at home. So in these next two slides, we're going to look at fever and what it develops at 0 to 2 days post-op, 2 to 5 days out. But here are just some common things that can cause fever. And I'm not going to go over all this because, again, we have a lot of data here. But I want you to know that all this is accessible to you, and I'm accessible to you to review. But here are some causes of fever 0 to 2 days out. Here are some causes of fever to 3 to 5 days out. These are not, set in stone, but generally when you get fever at these dates, these are things that you want to consider. Here's fever at 5 days out and what to consider. So fever is a big one. Elevated pulse rate is another one. If you get an elevated pulse rate from a patient that's had gastric bypass or a gastric sleeve, we know that's a leak until proven otherwise. So don't ignore fever or don't ignore elevated pulse rate when they come into your practice. Many physicians will think to themselves, well, this patient's just been in a hurry, that's why their pulse rate's up. If they've got an elevated pulse rate or mild elevation in fever, you need to track that down and rule out these complications. So here are some other early complications. Respiratory, there's an array of respiratory problems from mild atelectasis to acute respiratory failure, pulmonary edema. Respiratory complications are quite common, occur up to 15% of the general anesthetic in major surgery cases have some sort of respiratory. That's why we strongly encourage patients to do these respiratory therapies, and you've all experienced this in the hospital where we have patients doing their respiratory care where they're blowing into a machine and making sure that they're getting good pulmonary function. So these early complications are atelectasis, pneumonia. Other early complications, we talk about this, deep vein thrombosis, risk are obese patients, smoking, length of surgery, venous stasis history. They may have a history of this, oral contraceptives, and then sitting for a long period of time in a flight, puts you at risk of these deep vein thrombosis. So the role of the destination surgeon is to review the medical surgical complications, provide a discharge plan, homegoing instructions, and share their operative reports, their discharge summary, and with the patient's primary care physicians. Now, how do you do that? Web-based portals that are secured would be one way. Email, we don't recommend that. I think at some point we'll have more secured email that we can do that, but currently we don't. You might fax it, or it may be just paper mail. More likely, it could be something that you've handed to the patient who's now handed it off to the primary care physician. You want to continue this line of communication between primary care physician and surgeon. You can do that through email, cell phones, your communication portals at your hospital, or Skype. But the communication is important. It's not only important to help reduce risk, it's there to help ensure best outcomes. Because if you do surgery and your outcomes aren't as good as the surgery done in another location on the planet, you're not going to get surgery. You need to prove that that hip that you did produced long-term and durability in terms of patient outcome or bariatric surgery and so on. So communication is important. And the third benefit of communication, it raises referrals. You get more referrals. So let's look briefly at the postoperative travel, the role of primary care physician, to look at those reports that are being sent back to the physician, the medical surgical reports, the discharge summaries. Begin to discuss with the patient the early treatment phases and long-term treatment phases. To look at postoperative complications, late postoperative complications, and that's up to 4 weeks post-op, and clearly that patient will be in the office in the care of the primary care physician. And then look at postoperative long-term complications, 4 weeks out. 4 weeks out, 2 months out, you can have complications with bariatric surgery. You can have complications with cosmetic surgery, dental surgery, orthopedic surgery. Things can go wrong, and that's why we want these patients engaged long-term postoperatively with the primary care physician. We're trying to not only reduce risk, but improve the best outcomes so that destination surgeons will reduce their exposure to risk. So postoperative, post-travel, referring physician needs to communicate with their destination surgeon, and we do that again through mail, email, fax, web-based communication tools. Communication is critical to reducing risk and complications. In the early phase treatment plans, you want to talk to the patient about respiratory and cardiac care, wound care, physical rehab. You discuss with the patient medication changes. If they're a patient undergoing bariatric surgery, we know how rapidly we're changing CPAP, diabetic medication, and hypertensive medication. So you want to ensure that the patient is following up frequently to adjust those medications, and then follow up with any specialty care the patient may need. A specialty care, an example of that might be a patient who has had orthopedic surgery may need to have physical therapy or occupational therapy postoperatively. So here are some early phase treatment plans for respiratory therapy, the spirometry to improve respiratory health, CPAP adjustment, maybe pulmonary consult, same with cardiac therapy, rehab, potential consults that will be necessary when the patient returns to care. Early phase treatment plans for wound care. When is it necessary to engage the destination surgeon into these wound care issues? How frequently should the dressing be changed? Are the sutures to be removed or staples? And if so, who does that? Do you want that done by the primary care physician or a specialist in that patient's home of origin? You want to look for signs of infection. Signs of infection are critical. Any redness or swelling or elevated fever needs to be addressed. Physical rehab, we talk about early ambulation, ambulation aids, walkers, beds, wheelchairs, making sure that some of this stuff is in place before they even come home through that preoperative, pre-travel examination. Some of our cardiac or our orthopedic and cardiac patients will need in-home PT or OT. And there's got to be goals here of one to lift, one to start the range of motion, one to increase range of motion, and strength training on orthopedic cases. Medications, primary care physician needs to adjust the medication. There's adjustment to the pre-op. As we discussed earlier, insulin may be out or cut in half on these very surgical patients, but you need to frequently adjust other medications. There's the new medications that the surgeon has put on. When are they adjusted? So these are things that you need to discuss with the patient and why it's so important for the primary care physician to be engaged and engage frequently postoperatively. Sending these patients home to avoid is just a recipe for a disaster. These patients are going to have complications, and if they have complications, who's going to hear about it? Their physician and other physicians in that community are going to hear, well, this patient went to an international destination, came back and had this disaster. Well, these disasters could have been avoided if we can get physicians, primary care physicians engaged, and that's why we're taking such great effort to engage primary care physicians around the world to make sure that they're part of this continuum of care. Diet progression, this is for patients who have had GI surgeries, whether it's a gallbladder or some other bowel resection or cancer surgery or bariatric surgery. How is their diet going to progress? And we give specific details. If any of you are interested in guidelines that the ASMBS has issued on diet progression for bariatric surgical patients, I have access to this data, and I'll be glad to share it with you. But again, you want to progress the diet and understand when the diet should go back from full liquids to clear liquids under what circumstances. That this is also something that we'll talk about in greater detail in further CME programs. This presentation is meant to be sort of a global overview of a general surgical patient, covering patients that are traveling, whether it's bariatric, orthopedic, or cosmetic, or dental. And as we move forward, we'll create CME programs specifically for a orthopedic patient, or a cosmetic patient, or a bariatric patient. So early phase treatments, we want these patients to follow with the physicians frequently. I like them in the first day that they come back. I want them in 1 week after surgery, 2 weeks after surgery, 6 weeks after surgery, and as needed. Now, these are my personal recommendations. This isn't a standard recommendation by any credentialing agency or medical board or anything like that. This is just generally what we have followed in our bariatric surgical patients and found to be effective in intervening early in medical complications and improving long-term outcomes. These may be varied based on what the destination surgeon wants. Maybe the destination surgeon wants you to see the bariatric surgical patient twice that first week because of the rapid return of a normal fasting sugar. Or the orthopedic surgeon may say, gee, you don't need to see him 1 week out, 2 weeks out. See him at 2 weeks out, eliminate that 1 week visit. But my concept is that the more frequently you see this patient, the less likely we are to have a surgical complication or or we can intervene on that complication and reduce long-term disability and cost. You need to talk to the patient about specialty follow-up as well. When do they go back to the destination surgeon? Some cases they do. I know a lot of my cosmetic patients go back because they'll have a procedure and then they'll go back and follow up with that destination surgeon on that procedure, say a rhinoplasty, and now when they're back the second time for follow-up, they also schedule maybe a dental procedure or a liposuction or something else. So many of our patients will go back to the destination surgeon. Most, however, don't. They're back here in the States. And so what do we do in terms of complications if they get here in the States? The orthopedics, do we have a good line of communication with an orthopedic surgeon? If it's bariatrics, do we have a communication line there? That's important for you as a primary care physician to develop, and we are going to help you with that process. We want to help you engage the specialty physicians because our goal is to ensure risk reduction and best outcomes. And to do that, we need not only referring physicians to be engaged in this continuum of care, but we also need specialty physicians to participate. And what I've found is I travel 50 to 60 cities a year in the United States at least, as I travel extensively through the U.S. I'm finding subspecialists that want to participate in delivering aftercare, even if they have not done that surgery, because they see this as a way to deliver additional services and to network with surgeons whereby they may be participating in aftercare. For example, say a U.S. surgeon, bariatric surgeon, has a patient that goes to India or Costa Rica. When that patient comes back, that U.S. surgeon may provide care knowing that at some point there'll be a patient coming from outside into the U.S. to have surgery. So they're trying to develop a relationship with these destination surgeons to provide cross referrals. There's incoming and outgoing international business and domestic business. Postoperative, when to follow up. These are important things to keep in mind. I don't want to go into the details here, but if you have a patient, for example, that have had bariatric surgery and they have elevated pulse rates, that's an asthmatic lead until proven otherwise. You have mild fever, that's something to be aware of, could be a concern too. Disordered and wound healing for blood supply, if they're back to smoking, that's going to be an issue. Long-term steroid use, a lot of our patients have orthopedic conditions or are using steroids to control and manage inflammation and pain. Those patients have terrible healing processes, so we need to be aware of that. So vitamin, mineral, macro, and micronutrients are important for wound healing as well. Wound dehiscence, when that wound opens up, what do we do? When do we go back and do a primary closure, or do we let that heal secondarily? When does it happen? These are things that need to be addressed, and things that can be managed, cooperatively managed at home with the input of the destination surgeon. So the destination surgeon needs to be contacted when these wounds open up, and they'll walk you through as a primary care physician what you need to do, what they feel comfortable with you as a primary care physician doing, and where they think this patient needs to be sent off to a specialist in their home community or return to the destination surgeon to address the wound healing issue. Incisional hernia, we see this occasionally, but now that we're doing most of our surgeries laparoscopically, it's rare. It's rare that they do an open laparotomy surgery. Occasionally, though, a patient will come in for a laparoscopic surgery. Something goes wrong, they need to do a laparotomy, open that patient up. In those cases, you may get an incisional hernia. This helps you understand when they happen and how to manage those. So what we've discussed here is the continuum of care for the traveling patient. We looked at the role of the primary care physician, the referring physician, in terms of pre-op, pre-travel, how to reduce the risk of travel, how to ensure that the patient gets to the destination ready for surgery. And then we looked at post-op, post-travel. What are the steps of engaging that patient post-operatively to reduce post-operative risk and complication and cost. We also discussed the role of surgeons and destination hospital in this continuum of care. Our goal here is to begin to communicate and engage physicians and surgeons from around the world. Our technology is driving patient access to global health care. The artificial barriers that we've created in our world are falling apart and melting away as travel becomes more accessible, as communication becomes more accessible, as we're finding patients traveling. There are individuals that are opposed to any change in healthcare. They like things the way they are. They want it to stay that way. And they just can't stop this change. This is coming. Medical tourism was driven initially by patients that had more affluence and were able to go to destinations to find the best surgery at the best cost. But it's now being driven by employers and health insurers, anybody and everybody who wants to find high-quality health care at an affordable cost are looking at domestic and international travel. So this is a topic that we need to drive to our referring physicians. We need to communicate well with our destination surgeons, and that is what has driven us to create some of these educational platforms. As I said, as we go forward, we'll have additional, more specific educational platforms on, for example, cosmetic surgery, how to manage a patient prior to liposuction, post-liposuction, dental procedures, orthopedic procedures. But this was just a sort of an overview. I appreciate you all attending this. We'll have an opportunity in a moment to take questions, and at any point I will be able to pass along my contact information, and I'll be glad to help in any way I can this process of delivering continuum of care to reduce risk, cost, and improve outcomes. At this point, I'm going to turn it back over to Amelia, and she will help us with the process of taking in questions and answers.
Hello, thank you, Dr. Huffman. That was a great presentation, and thank you to everyone for joining us. There's a lot of really interesting information. So I just wanted to briefly, like Dr. Huffman said, we are looking to develop more medical education like Dr. Huffman has presented today, because that's one of our main goals with the Medical Tourism Association is to educate physicians. So Dr. Huffman is so great. He's going to be leading a medical education committee with us. The purpose is to help provide oversight in government to the medical education that we, the MTA, provide. And so we'll be seeking more physicians and surgeons, both destination and primary, to join Dr. Huffman in developing these continuing medical education courses. So I just wanted to let everybody know that we'll be hosting a special medical education committee meeting at our annual conference. So if anybody, any physicians or surgeons that are interested in joining Dr. Huffman and developing and putting their input in, please contact me. My contact information is on the slide. And you can send me an email or give me a call, and I'll be happy to send you more information of how you can join that initiative. In case you don't know, we are hosting our annual event. I just wanted to put that out there that we will be including more information like what Dr. Huffman presented. He will be attending and presenting again this year. It's September 20th to the 24th in Washington, D.C. You can find more information on our website, but it's a really great event. So anybody in the industry, we encourage you to join us, and learn more, get more information like what you saw today. We have about 3,000 attendees we're expecting, 100 different countries. So if you haven't been, I highly encourage you to go check out our website. We do still have our early bird discount for a few more weeks, and after that it'll go up another $500. So definitely check that out. We just have a few minutes for questions. I see a few come in, but you can feel free to type in that bottom right corner that says Q&A. So type in your questions there. We'll try to get as many as we can answered over the phone or over the webcast. But if not, then we'll have Dr. Huffman can reach out to you and address them directly and individually. So one quick question that we have from Suzanne, and she wanted to ask, as a primary care physician in the U.S., what happens if you disagree with the medical direction the patient has decided to take? What are the options for the PCP in an opting to care for when something goes wrong at home?
That's a very good question. I think as a primary care physician, you should question the procedure and vet out the surgeon and vet out the institution. We're trying to do some of that as well. We're looking at JCI-approved hospitals, make sure the physician is qualified, look at their 30-day outcome data, the risk, 30-day risk, infection rates, and all that stuff. So I have, in fact, had patients who have made a decision to go somewhere and block that access based on what I felt was in their best interest. That's rare, but some of these patients are finding places to go that just haven't gone through enough and don't have enough experience, or they're not well vetted out. So if you feel there is a that it's in the best interest of the patient, just advise the patient. Tell the patient, say, listen, I think it's a great idea to seek out low-cost, high-value care, but let me help you find something other than this choice, or let me do a little research on my own before you do this. So we may push your surgery back a couple of weeks until we feel necessary. Now, I think another part of your question was, what happens when it goes wrong at home, and what are your liability risks? Well, the things can go bad at home. They do, whether they're domestic or international. They go bad if your patient goes away and doesn't tell you, and they show up at your office. You still have to treat that patient, unfortunately. And that's what we saw with our bariatric surgical patients. They wouldn't tell anybody. They'd just fly off and get a surgery, and then they'd come back with a complication, end up in the emergency room, and we're forced to care for those patients. So if it's your patient, you're kind of stuck. And that's why we think it's important that you do get educated and you seek out more and more of this sort of knowledge base so that you feel comfortable. As far as your risk in approving this, I don't know if there's a risk for you endorsing it, or if you are endorsing it in any way. What you're telling your patient is, you as a patient have made a decision to go away. Here's your consent form. You realize these risks. I'm not necessarily endorsing what you're doing, but I'm providing those services, those level of care that I've outlined here. So that's a hot topic, to be honest with you, Doc, and I think it's something that we'll be discussing further, medical liability and what risk. Thank you for that question.
Thank you. So we are short on time, unfortunately, but I do see there are some other questions coming in. So I'll have Dr. Huffman can go and address those questions to you each directly. And please, if you are interested in joining the Medical Education Committee, my contact information is there. Hope that you'll join us at the Congress, and hope to see you in DC. Thank you.
Amelia?
Yes.
I have one question. If they're going to type in some questions that I'll be able to answer directly for them, is that what you're saying?
Yes, we can. We have some questions that they can send in directly. They can email me, or if they want to type them in box, and I'll work with you to answer them directly.
Great. Thanks everybody. I appreciate it.